Hello, my name is Hester and my pronouns are she and her. I'm NHS England's Head of Patient Safety Policy, and today I want to share the Patient Safety Healthcare Inequalities Reduction Framework with you. I'm sorry I can't be there in person, but COVID has somewhat got the better of me. So within the 2019 Patient Safety Strategy, we committed to patient safety healthcare inequalities reduction. However, this commitment needed to be finessed with real information and evidence so that we could start to understand what was needed. And first of all, we needed to understand who was affected by inequalities. So we considered people's 9 protected characteristics and those who were part of inclusion health groups. Here is a non-exhaustive list of those marginalised communities of people. And we know that evidence shows that people in working class jobs, those who are from ethnic minority backgrounds, those who live in rural or coastal areas, those who live in deindustrialised inner cities, those who've experienced domestic violence or who are homeless, are sadly more likely to experience worse NHS access, worse outcomes, and unfortunately to die at a younger age. In the 10-year health plan, this is described, I think somewhat accurately and sadly, as an intolerable injustice. We wanted to really understand how these inequalities occur. Many, we know, are due to socioeconomic disadvantage, though they're also exacerbated by how we interact with the people and communities we serve. We need to consider the barriers that mean that our services are harder to reach, particularly for those from marginalised groups. Within the 10-year health plan, we've pledged that the NHS will be a service equipped to narrow health inequalities in both access and outcomes, as well as to give everyone, no matter who they are or where they come from, the means to engage with the NHS on their own terms. We considered why healthcare inequalities matter, understanding that there are significant impacts on healthcare for those in different communities, and that these impacts are wider than just the direct impact on those affected. Most obviously, people's own health outcomes are affected if they're unable to access healthcare easily, perhaps due to challenges with digital interfaces. This then reveals injustices in the system that further lead to mistrust as communities recognise that people who are patients may find it harder to make their voice heard and experience discrimination. Ultimately, this also has a financial impact, as when people do not feel equally included in or offered healthcare opportunities, their health will be impacted, and this will cost the system more in the end, for example, to address late diagnoses. This also has a knock-on effect to public health, as we've seen in screening programmes. For example, research has found that in England, cancer stigma is linked to lower screening uptake, and this is more common among people from ethnic minority backgrounds. And when we looked at the available data, what this means in reality is, that Black women are 2.3 times more likely and Asian women are 1.3 times more likely to die than white women when giving birth. 39% of trans and non-binary people were not confident in using their GP. Black children are 10 times more likely to be referred to CAMHS via social services rather than through their GP in comparison to white children. And 67% of sign language users have been denied professional communication support at some point in their healthcare journey. So our journey to develop this framework began with setting up a task and focus group. And we recognised it was really important for us to recruit staff and patients to the group who were as diverse and representative as possible. So the group included providers and commissioners and patients representing key stakeholders who have lived experience or expertise in inequalities, with leads from across different healthcare sectors, regions, and very much included patient safety specialists and partners. And we looked at all the evidence. And Kean Wade's publication in 2022 in particular highlighted a selection of mechanisms that increased risk of harm for certain patient groups. Represented here in this infographic, the central circle shows the stages of a patient's healthcare journey during which any of these mechanisms may apply. The outer circle represents 4 overarching themes: access, communication, bias, and support. When we talked about patient safety, healthcare inequalities reduction, we recognised we needed to clarify what we meant. If you look at this slide, the initial section in white is the standard definition of healthcare inequalities, to which we've added the blue section, describing that healthcare inequalities include unequal access, experiences and outcomes within health and care systems, and when these inequalities cause harm or increase the risk of harm to patients in healthcare, they are patient safety healthcare inequalities. So the framework published this year was developed to enable greater understanding of and develop solutions for how we can reduce patient safety healthcare inequalities to help close the gap by mitigating the risk of harm to patients caused by the system, organisations or workforce. And we set out 5 principles. The first principle is around communication and information, with our ambition for all staff, patients, service users, families and carers to have access to information, translation and interpretation services when needed. As part of this, we committed to publish a framework for community language translation and interpretation, which is now available online and which we will continue to promote. The second principle is around training and resources. We want all healthcare staff to receive patient safety training from undergraduate level through to continual professional development. And we wanted to create accessible resources that improve their awareness and understanding of healthcare inequalities related to patient safety risks. As part of this, we're co-developing a series of role-specific top tips for use by individual clinicians, organisations, patients and communities, which will be published as part of a wider patient safety healthcare inequalities reduction handbook. The third principle is about accurate and complete diversity data. We'll be encouraging and enabling improved data collection of protected characteristics and other health inclusion groups on digital platforms. This work includes making disaggregated data available so evaluation can drive improvements in patient safety and healthcare inequalities. And we will be developing the Learn from Patient Safety Events service to record the protected characteristics of those involved in patient safety events, so that we can start to identify when patient harm is more common in specific groups of patients and whether there is any case selection bias in different approaches to patient safety incident responses. Principle 4 is around diverse co-production, and representatives of diverse communities are involved in the design and delivery of improvements aimed at reducing patient safety healthcare inequalities. This very much means that we'll continue to promote the recruitment of diverse patient safety partners and showcase their value in co-production in all areas of patient safety improvement work. And finally, Principle 5, research. We know there is not enough research on patient safety healthcare inequalities, and we aim to improve the understanding of and drive improvement through identifying priority areas for research. So we've been working with stakeholders to strengthen the inequality focused within the Strategic Patient Safety Research Needs Annual Update. And this will then be shared at the next round of NIHR funding. Putting these 5 principles into practice, we wanted to emphasise intersectionality and to ensure that we learn and consider individuals and their stories to really comprehend how we can start to improve diversity. Thus, we feel the most important aspect of this framework is the experiences that informed it, stories of suffering and loss that were bravely shared so we could learn and improve patient safety. These personal stories are all available online and I encourage you to read them. Also, I'd particularly like to take a moment of reflection to show our thanks to the people and families that shared their stories. Reducing patient safety healthcare inequalities may feel like an additional task in an already stretched environment. However, there are some significant benefits to these relatively small changes that intend to reduce rather than increase workload in the long run. These benefits will affect patients, staff, organisations and systems, and we've presented some of these here focused on patients and staff. So we know that fewer people will be harmed, especially those from marginalised communities. There will be fewer complaints as culturally sensitive communication improves. People, patients, families will feel more able to raise concerns with staff. People will feel safer and listened to within healthcare with less discrimination, and so they're more likely to seek help earlier. And we want people that are involved in the co-production and delivery of improvements so that these are tailored to the needs of people who really require them. When we think about staff, we want to make sure that staff have an increased confidence and understanding of patient safety, healthcare inequalities reduction. They will also have an increased confidence and understanding of how to access translation and interpretation services 24/7. We want staff to have a good idea of how to make accurate collection of diversity data possible, ultimately leading to a better understanding of where and how to target our resources. And we know that increased staff diversity leads to more improvement and more innovation in the long run. So I particularly want to highlight the importance of co-designing with patients and communities, and it cannot be overemphasised. In particular, two of our patient safety partners, pictured here, Khadija and Priscilla, have been involved in our inequalities reduction work from the very start. And I wanted to take this opportunity to both formally recognise their contributions and to demonstrate the immense value of their input to this work. They have directly contributed patient stories and case studies that enabled the inclusion of patient safety stories from people from diverse backgrounds. They have ensured that we accurately reflect the breadth of diversity of communities that access and support our NHS within this framework, and that the framework has been written in plain English to the best of our abilities. They have presented on patient safety, healthcare inequalities reduction at multiple forums, and they've also produced a podcast on PSP involvement in inequalities reduction with just over 17,000 hits. And I very much encourage you all to go click on the link and listen to their story. So what can you do to reduce inequalities? The recommendations shown here reflect ideas and actions from within the 5 principles. And particularly, we've highlighted them against the key aims of the patient safety strategy: involvement, insight and improvement, and they're underpinned by inclusion. I won't read these all out as the slides will be made available to you after the symposium. However, for example, we know that if data isn't complete or consistent, it limits our ability to fully understand people's experiences and needs and holds us back from tackling healthcare inequalities effectively. And we know that data are essential for carrying out effective service planning, quality and patient safety improvement, and monitoring the equity of services that we provide. We can see that individually, making small changes to improve the quality and completeness of diversity data means we can start to have an impact on inequalities reduction, even if that is just one single data point at a time. So one of the lines in What Else You Can Do there was reviewing your local population to identify marginalised groups. Now, this may not be something that easily falls within your patient safety skill set. So I've included here some pointers to help you get started as to where you can access this information. So in your local authority, public health teams produce a joint strategic needs assessment each year. Your local NHS has a health information team and they can provide GP level demographics. The Office for Improvement in Disparities, OHID, provides fingertips profiles that are available, and the Census 2021 data is also available at local authority level. So these all give you places to start. And we're already starting to co-produce role-specific top tips that will be included in our handbook. Here's the patient safety specialist draft. The idea behind these tips is that they are realistic tasks within the gift that someone in that role can do to shift the dial on inequalities. The first 5 here for patient safety specialists relate to including patient safety partners as part of incident response oversight, ensuring that the organisation's published patient safety incident response framework plan includes how patients and families have been involved, ensuring that patient safety partner recruitment is fair and inclusive, and using any issues relating to translation interpretation services to help support improvement projects for the future. I particularly like to emphasise that working together collaboratively with inclusive, diverse human connection is ultimately what starts to reduce patient safety healthcare inequalities reduction and improves safety culture at the same time. So here are all those who collaborated on developing the patient safety healthcare inequalities reduction framework. My thanks to all of them. And finally, a few acknowledgements of the group and others involved, particularly Dr. Aoife Malloy. And I would just like to say, I'm really sorry I can't be with you there today. I can't take any questions because I'm not there, but I'm more than happy to be contacted by email. Thank you very much for your listening.